we actually made a pathway.
Correct.
And we can somehow, like in extreme situation, when the nurse, like, I don't know what to do with this patient, but there is something.
Yeah, oh, absolutely.
The trouble, and you would know, even like, I don't know, just know. I don't know why,
yeah.
but I just know
exactly.
This is what I need to do or something.
Yeah, I have time. Are we going to do those questions?
Yep. Let's get through the rest of the fun for this chapter.
I did track the quizzes due on Monday at noontime.
Monday at noontime. Okay, good. Is that okay with everybody? So that'll give you a whole, it'll give you a whole day if you want to review anything you might have gotten wrong on that the quiz. Oh, what's the matter?
I won't be able to review anything.
Well, you'll be okay.
Bah humbug.
Bah humbug.
Hopefully you'll just get 100 on the quiz.
There you go. 105.
I have a question about that. You're right.
What? Quiz?
Yeah, I tried to review the last one and I couldn't.
You can?
Worked for me.
Go try again. Let's see you after class. Maybe you're just clicking in the wrong place or not going down far enough. Or
It's there, but it says this isn't. It said this isn't. Send me back for review yet. I'll try it.
yeah, try it because it might have been maybe you tried to check it before the due date.
No.
No, it was after the due date.
Oh, that one said that it wasn't
Oh, you.
until 6 p.m. for some reason. Yeah, that
Oh, you know what? That's when I screwed up and put AM instead of PM. So I made it due later. That's why. So I bet you it's okay now. Having issues with the whole clicking the right buttons. It's a good thing I'm human.
Wasn't it actually due sooner?
Yeah, instead of P, it was supposed to be 12 whatever PM, and I put AM. So I made it due later so that if somebody messed, because I screwed up. So it should be okay now.
the next day.
Yeah. Okay, so white blood cells. How many different kinds? 5. What are they? Never let monkeys eat bananas.
Monocyte,
Monkeys. Never let monkeys eat bananas. Neutrophils, lymphocytes, monocytes, eosinophils, and bananas, basophils. 3 of them are granulocytes. Who? Right. And the A granulocytes? Lymphocytes, monocytes. Okay, and we talked a little bit about their physical characteristics. We won't talk about as much or be tested on that stuff. That stuff is going to be helpful for you in lab. So when you have to actually go and visually identify the different types, those hints I gave you in class are going to help you with your microscope work. Okay, so what is it? We already know what causes the hematopoietic stem cell to become an erythrocyte.
what helping?
Yeah, what causes it to mature into an erythrocyte? To who?
Hormonal signal.
What hormonal signals?
EPO.
Erythropoietin, EPO, right? So what the heck is it that causes all of these different guys to become all the different guys it's going to be? Well, there's a whole bunch of different chemicals. Now, this is one of those things where can you see it now? Yeah. Okay. There's groups of different chemicals, different ones for different cell types, that will cause this cell to mature into all of the different cell types. Basically, what I want you to remember, the stimulatory factors that are going to cause that cell to become one of the 5 are groups of chemicals called interleukins and colony-stimulating factors. And those are on page 642 under production and lifespan of leukocytes in your textbook. 642. There are a whole bunch of different ones. Again, I'm not going to make you memorize all the different ones, But what I want you to recognize is those two terms, interleukins and colony-stimulating factors. They are going to cause that cell to mature into one of the 5 players in the leukocyte family. What's the term leukopoiesis mean? Production of white blood cells. Remember, erythropoiesis was what? Yeah, production of red blood cells. Okay? So, that's what I want you to know as far as who causes that cell to become a white blood cell. One of the 5 white blood cells. Yes?
Those are chemical messengers.
Correct. The next thing the book talks about is leukocyte disorders. Now there's 5 different types of leukocytes, correct? So we can have 5 different categories of disorders. General disorders of leukocytes are defined as what? Leukemias. Now there's different leukemias based on what the result is from the deficiency or overproduction or malproduction, whatever it might be. We have a whole bunch of different leukemias. Basically, I want you to understand that it's a disorder, sort of cancer of these white blood cells. Not necessarily. It could be abnormal production. It could be they no longer function the way they're supposed to be. So abnormal cells, abnormal, exactly. We could have basophilic leukemia, so that would affect the basophil group. We could have eosinophilic, and so on and so forth. So just understand the general term leukemia and understand that it is a disorder of these white blood cells in some way, shape, or form.
But there's a leukopenia.
Yeah.
Which
Is that a leukemia? Is that a leukemia? No. What's leukopenia?
yeah, it's a
Low. So you're not making enough. Okay, the cells are normal, but you're not making enough for some reason. Could be a chemical disorder. Could be some other disorder that's preventing you from being able to produce these cells. Another one under leukocyte disorder is something called infectious mononucleosis. And some of you might have experienced this lovely little Epstein-Barr virus in your lifetime. That's mono, yeah. Mononucleosis. It's a leukocyte disorder. It's not a leukemia, it's a disorder of leukocytes.
And what is that? Because just in the book it says like highly contagious viral disease.
Yeah, it's a viral disease that does what?
Flu, but way worse.
Yeah, it causes a lot of symptoms like very tired, and yeah, and what we're going to see when we look under the microscope at that white blood cell differential count is we're going to see a group of cells that will produce more of themselves to try and fight this virus off. Now, when I said viruses last class, which cells come to mind with respect to fighting them off? Which white blood cell?
It's neutrophils.
Virus.
Virus.
Lymphocytes. Exactly. Those T cells, those B cells. When I want to fight off a viral infection, I'm going to have an overproduction of the lymphocytes. And what we're going to see in that differential cell count is a higher number of lymphocytes that tend to be larger than some of the normal ones I showed you. We call them, when we look at them in the microscope in the lab, we call them atypical lymphocytes. So we're going to see higher numbers of those lymphocytes during an infection with infectious mononucleosis. And again, it's a virus called the Epstein-Barr virus. So when we look under the microscope at that tiny little drop of blood, we can give the clinician quite a bit of information. If I start to have higher numbers of any of these formed elements, I can then go further and say, okay, are these cells normal? Are they abnormal? What kind of cells do I see? If I see, and that's one of the quickie screening test to see if someone has mono. They come into the doctor's office. And mono is an abbreviated name for mononucleosis. So they come in, oh, I'm so tired, I can't seem to do. They tell the clinician their symptoms. What's the quickie way? Yeah, and why do you think her neck was swollen? Yeah, because what? Lymph nodes. When we talk lymphatic system, guess where a lot of these lymphocytes hang out? In your lymph nodes. So when we have a disease like a virus or even an allergy or
My daughter's lymph nodes swell right up.
huge,
Right in the summer.
because those cells are multiplying, trying to fight off the invader. With respect to a virus, there's cells in the lymph nodes that will then recognize it as foreign and then multiply and elicit an immune response. So when we talk about that in the immune system, we'll understand why those lymph nodes get so big. Okay?
So I had mono really bad when I was a senior in high school.
Yeah, a lot of kids in that age range seem to be susceptible.
I got a horrible rash that covered my entire body.
Yep.
They said it like 10% of people it was mild. What caused that?
It's your body's reaction to the invader. So you're gonna elicit an immune response, and we'll talk, when we talk immune response, we'll talk about things like hypersensitivities and your body's reaction to different antigens, foreign substances. Everybody acts different. You know, different medications can bother people, or you react differently to different medications than maybe somebody else. And that has to do with the way your body recognizes these substances in your body.
So it's the same thing with viruses as well?
Yeah, it could be virus, bacteria. Some people get like widespread systemic reaction from their immune system from different things. Yes?
Well, my son got strep throat and he got all over his body. Right?
Yep.
And they didn't. Well, the thing is like he was put on an antibiotic that I think he became susceptible to because he's allergic to any penicillin.
Resistant to?
He can't have any of that. So they put him on September19, which is the only thing that he can pretty much take for any infection. And so they had him on it for 5 days, I think, and then I thought it was gone.
Yeah.
So we let him go to school, blah, blah, blah. And he came home, and he was itching all over the place. And I'm like, what is wrong with you? And I took off his clothes, and he was covered. And I was like, oh my God. And I freaked out and called the doctors.
Yep.
He still has strep throat. And I'm like,
Yeah,
oh,
and
I
it's
don't
his
get it.
body's way of reacting to the foreign substance.
But how, a rash from strep throat?
Yep. And just the toxins in his system.
It didn't make any sense. I'm like, I've never heard
And
of
if you
strep
want to look it over before we get there, look over the section on hypersensitivities in your chapter, whatever it is, 22 maybe? 22, 21, 22? Can't remember, the immune system chapter.
Yeah.
And read that over and then you'll understand.
We had a patient that had a UTI, and just that UTI, she
Yep.
was covered in a full body rash, and then it peeled like it was a sunburn.
My poor father, that happened to him as well.
I mean, my heart went out to her, but it was so cool.
It's kind of like a spa treatment for her.
It's weird because as a mom, I treat kids, but after I had my first one, I got allergic to a lot of antibiotics.
Yep.
And with my third one, they were able to use my phone, and it was fine. It's just
Yep, and it's exactly, and there's a lot of shifts in the way your body responds to things. Allergies, for example, seasonal allergies. You know, it tends to go in waves, and I don't know if this has a scientific basis, but a lot of people say every 7 years your system changes, and it's true. You know, Yep, better or worse. I started suffering from seasonal allergies when I was in college taking, ready for the class, vascular plant taxonomy. In the fall. What was I thinking? I was dying. We're out there identifying plants and I'm crying and sneezing but I never had an allergy until that point. I had them terrible, terrible, terrible until a few years ago when I started now to get much better. So,
Is it chapter
21? Yeah, it's probably
For
21.
lymphatic system?
21.
Is 21?
Yeah.
This is talking
hypersensitivities.
It makes sense though if you think about it, like children, if they have like milk allergy or something when they're babies or something, sometimes grow out of it.
Well, and that's all, you know, if you look at lactose and lactose production, we have a gene that creates lactose, and then we have a gene that turns it on. Okay? So sometimes the gene that turns it on is lacking and then kicks in later on in life. Sometimes it works the opposite way. The gene that kicks it on shuts off later on in life.
Well,
So.
it's not, that was just an example. Like, my daughter's dad was allergic to antibiotics from when he was a baby. And
Yeah, overexposure.
baby, and he was about 8, and then they accidentally gave him some penicillin, and they thought he was going to have this huge, like, anaphylactic reaction.
And he didn't. Yep. So yeah, when we get there, we'll understand how the body, sometimes it just goes into overdrive with respect to immune response, and those cells just go berserk. All right, let's continue with this wonderful chapter now. Good job of stalling, guys. I commend you for that. Platelets!
Now you can't test this on.
Oh, yes, I can. Platelets, platelets, platelets. Of course, coming from the same cell, hematopoietic stem cell. What is it? First of all, what's a platelet?
For clot formation.
It's going to help with clot formation. It's not really, when we look in the circulatory system, it's not really a full intact cell. It's actually fragments of cells. When we start to make the platelet, we're going to differentiate that hematopoietic stem cell into something called a megakaryoblast. Mega. What's mega mean? Really, really big. Well, this cell is really, really big in the bone marrow. And as it goes through its progression, the final stage before it gets spit out into the circulatory system, just like everybody else in the bone marrow, is called a megakaryocyte. When that cell goes to squeeze into the circulatory system, guess what happens to it? It blows up, breaks apart. And the fragments is what we're going to see inside the circulatory system, platelets. It's not. But the fragments are still going to allow for chemistry to happen. Chemical reactions can still take place because of the chemical components we're going to find in a platelet. Okay, platelets don't last that long, but they're going to help with clotting. So, platelets. Another name for a platelet. Do you know what it is?
It's not in a book.
No, it's not. And that's why we come to lecture, so we can tap the knowledge of your professor. It's called a thrombocyte. What's a thrombus? What is thrombo? When you think thrombo, thrombus, thrombin.
This is like a clot.
A clot!
Clot.
Aha! My thrombocyte, platelet, another name for platelet, is going to help with the clotting process, help to form those clots. So the megakaryocyte breaks up, goes into the circulatory system, and the little fragments are going to help with the formation of clots. Now, why do I need to form clots in the circulatory system? Exactly, to plug up holes. Now, it's nice if everything can work fine and good, but you know, I get a lot of blood running through those blood vessels at any given time. Those cells take a beating, yes? The endothelial cells that line the tubes have to be repaired. They're epithelial cells, so we know that they can reproduce at a rapid rate, and there constantly is road repair going on. Or we might do what? Accidentally poke a hole into our circulatory system, right? So there has to be some way to patch up and repair on a regular basis and fix a hole when we get one by mistake. So the process of hemostasis, what's hemostasis mean? Well, first of all, hemo is what? Blood. Stasis? Stop. Yeah. Stop from bleeding. We don't want you to lose all of your blood volume. So one of the things that's important for us to know is and you all got your hints already, yes?
This was one of them.
This was one of them. So I want you to understand the steps involved in forming a clot, or hemostasis. And again, because I love those steps, and you're going to see that this whole semester. I'm kind of a protocol kind of person.
Wasn't that also in semester 1?
Yeah, when we talked about the integumentary system. Yep. So it's pretty much the same thing. Except we're going to go a little bit more into details as far as the chemistry of hemostasis goes.
Can I ask you a question?
Yes, you can.
So, what is the purpose? Because I know that, like, we were talking about the thrombus and everything, and people can throw like a clot, you know. What is the purpose of TED? Like, how does,
Of what?
like, the TED, like, the compression stocking?
Oh, yeah.
Like, what purpose does that serve?
It doesn't, it has more to do with reabsorption of fluids back into the system. Because what happens with patients that sometimes can't balance pressure in the system, one of the things we're going to find out when we discuss the lymphatic system is when fluid exchange happens at the capillary beds, more fluid comes out than really should because of the differences in pressure. And when you have a patient that has pressure problems, high blood pressure, or problems with kidney function that relates to pressure in the system, even more fluid comes out in the capillary beds than normal, especially in the extremities. Now, normally, if the pressure was able to be balanced in these patients under normal conditions, we'd take the excess fluid, we'd absorb some of it back into the circulatory system, and then the excess we'd absorb back into the lymphatic system. But because these patients have a problem doing that, we have to give them a little bit of help. And when we talk about the circulatory system, you'll understand. So we have to add pressure to push back into the circulatory system those fluids that have come out. Now, those patients also happen to have, as a secondary thing, problems with clot formation, spontaneous clot formation.
Yeah, because it always confused me, I guess, because I remember they were like, well, if they have because of DVT, they need to wear TED. And I get DVT, deep vein thrombosis, always just registered in my mind as possibility of clot.
Right. So that's another thing that happens because of all those excess fluids moving in and out. And it has to do with setting off prematurely this reaction that causes spontaneous clot formation. So what else do you give to those patients? You give them anticoagulants. And those chemicals are going to help prevent some of this chemistry from going on so clot formation won't happen spontaneously. Not necessarily. Certain diseases can mess with the chemistry too.
Doesn't it have to do with like movement and like daily active living?
It does, but not always.
Well, a lot of the times too,
Yeah.
like when I was working in the hospital, we saw TED on patients that had just gotten surgery of some kind.
Mm-hmm.
So it's not always.
Well, I know, but also they
Right.
have like pressure bags written on their legs if they can't walk for a few days.
Right. Because why?
Because of their blood getting a blood clot.
Yes, but do you understand if they're not moving, and this is what I want you to get to. One of the things, now think about pressure in my system. Heart's up here. Pressure. Moves blood through my system. My extremities, where's the pressure at? It goes way, way down. So how does the blood from my extremities get back to my heart? Well, people are, and again, I don't want to get sidetracked, but in the circulatory system, everybody's sort of pushing everybody along. So they get pushed from the heart, and everybody's pushing from behind. And I use this example when I'm in the lecture hall. It's a lot easier to visualize. But if I took all of my students in my class, and I lined them all up in the aisle, headed towards the door, okay? And I stood on one end of the room, and I took with all my might and pushed the first student, right? Everybody would domino, but then these guys over here and the ones closer to the door, they wouldn't feel that push as much, right? Because everybody would kind of compensate for it before it got to them. That's what... Well, everybody pushes everybody along, but by the time we get to the end, it's not going to be a big push. The pressure in the system in your extremities. Think of it that way. Okay, so the pressure in your extremities is much lower. How does blood get from my toes back up to my heart? Well, we have some pushing, but who else?
Vasoconstriction.
Muscle contraction. Muscles in my, I'm standing here, right? Muscles in my legs are going to contract. Watch this. All the muscles here are going to push on major blood vessels that run up the back. The ascending, descending aortas, you know, those big guys over there, we're going to talk about cardiovascular system. They're pushing on a lot of the major veins. That pressure is going to help get blood back into the circuit, back into the pump part. Okay? Why does what? Why does it help what? Again, what does it help with? If I have problems with pressure, lower pressure in the system.
My daughter was diagnosed with POTS syndrome.
Uh-huh.
And it has something to do with, like what you're just saying, you know, how the muscles, and she also, with the water retention, it's not being held in her veins, the water's leaking out, so that's why she's...
And water tends to follow what? When it leaks out? Salt. So if I can have a little bit more salt in the circulatory system, in her case, water is going to follow it.
That's why they had given her.
So it
But with the case of high pressure in the system, salt is not a help.
She's not a big salt.
Exactly. But do you see what I'm saying? When you ask a general question like that, you have to remember, oh my gosh, there's so many different reasons.
electrolyte balance, right?
And water follows those charged particles. So in her case, having more salt in her circulatory system where she's having an issue keeping water in is going to help her get more water back into the system.
This, aldosterone will help with,
If that's going to help with iron. Exactly. It's going to help with ion.
and potassium.
And that's going to equate to what? Sodium potassium balance is going to equal water balance, because water is going to follow those charged particles. When we talk about the renal system, for example, we're going to revisit the renin, angiotensin, aldosterone, that whole pathway. We just have a general understanding of it now. We'll understand even more how it affects the cells in the nephrons. And that's going to help then result in water balance. Okay? But sometimes salt, it's a bad thing if I have what? Too much.
My youngest daughter, she salts everything, tons of salt, but she dehydrates easy.
Why?
Because too much sodium, and that will take away,
Water from her cells.
because water is trying to follow that sodium, and there's too much sodium, so.
So it's such a fine chemical balance, and I know you hate that word, but it's so true. And then different diseases will affect those balances in different ways. All right, so hemostasis then. There are different steps. First of all, boom, I punch a hole in the circulatory system. When I punch a hole in the circulatory system, think of me just like an egg, cracking open cells and spitting out their innards. The chemicals that are then released into the circulatory system are actually going to act as attractants. To who? Platelets. So the platelets are actually going to be attracted to the chemicals that are being spilled out of those damaged cells, damaged tissue. The other thing that damaged tissue and its chemical release is going to stimulate is what we call vascular spasm. So that's the first step of hemostasis. Now, because of this chemical release, platelets are going to be attracted to the area. And when they are attracted to the area of damage, they're actually going to become a little bit sticky. And they're going to stick to the damaged region. When they stick, they're going to set off a chain reaction of events that is going to cause the release of specific chemicals that will begin clot formation. Now, so we have vascular spasm, platelet plug formation, and that's just basically a whole bunch of platelets that have aggregated to the area. And then we have coagulation. Not to scare the bejesus out of you or anything, but on page 647, table 17.3, we see a table of blood clotting factors. Oh, Jesus. Are we going to have to memorize this? No, absolutely not.
Which one?
Table 17.3 on page 647. Now, these 13 factors are very specific chemicals that are involved in a very specific reaction we call coagulation. I am not going to make you memorize them. Clear? But understand their importance in coagulation. I do want you to understand coagulation. Okay? Now, we'll talk about what it was and what it's going to be in a minute. But understand that all of those factors are involved in this process. There's two ways that I'm going to start this process, this chemical cascade to form a clot. One way is I'm going to poke a hole in myself. Yes? What do we call that pathway? Extrinsic, from outside. And what is that? What we just talked about. The release of, not blood, but, well, blood's going to leak out, but I'm breaking those cells. I'm causing trauma to the tissues. And they're going to release, remember those chemicals I talked about? Called tissue factors. Tissue factors then will set into motion a specific chemical reaction. And both of these scenarios that I'm going to describe will lead to the formation of this. That is what? It's called Prothrombin Activator. The other way I can form clots is the way I was talking about before, road repair. You know, those endothelial cells slough off a little. They become a little bit damaged and maybe need to be repaired. Well, during road repair, what do I have to do? I might have to block off the area and get rid of the old debris and put some new stuff back. So this is another situation where a clot may be formed, and this happens all the time. Unfortunately, sometimes in different disease states, it happens too much. And that's your patients you were talking about earlier. That is also going to lead eventually to the formation of what? Prothrombin activator. So we can have phase 1, formation of prothrombin activator. There's two ways to get there. It can either be intrinsic or it can be extrinsic. Understand the difference between the two basically in definition. So extrinsic, something from the outside breaks the cells. Intrinsic, something from the, and it's nice that they're named what they are because it makes more sense, right? Something from the inside causing this chain reaction to happen. But both of these are going to lead to what we call the common factors, and that's these guys down here. Both of them are going to lead to the formation of prothrombin activator.
So pretty much we need to know the platelet factor 3 and tissue factor.
Yep.
Just to know that.
And then know that that's from intrinsic, exactly.
Okay, and that will follow formation of prothrombin activator.
Correct. And then what's going to happen next? Now these substances that we see in this cascade, basically I want you to know the ones that are highlighted in white. Yes? These substances are floating around in the circulatory system. And normally, when they're not exposed to these chemicals, are in liquid form. When I start this chemical reaction going, I'm going to eventually form this. This is not liquid anymore. What is it? It's solid, fibrin. So when prothrombin activator is there and on board, because of this series of chemical reactions, it's going to come in contact with a chemical called prothrombin 2. When it comes in contact with it, it's going to change it. It's going to change it to thrombin 2. The presence of thrombin 2 is then going to come in contact with another soluble, floating around in the circulatory system protein called fibrinogen. It's then going to react with it and cause it to change into what? Fibrin. So it's going to take an insoluble protein and turn it into it's going to take a soluble protein and turn it into an insoluble clot. Yes? That's what I want you to know about coagulation. If I disrupt any of the other specifics in this reaction, am I going to be able to form a clot? I'll give you an example. Vitamin K. It's not directly involved in clot formation, but it's directly involved in the making of some of these clotting factors. If I, yeah, because it actually disrupts the pathway that vitamin K is involved in making these clotting factors. So if I have a deficiency in vitamin K, even though it's not directly involved in blood clotting, what's going to happen in clot formation? It's not going to happen because I can't make the factors that vitamin K is involved in helping me make. Again, I'm not going to make you memorize those 13, but understand that the formation of them properly is important for the clotting cascade, and that's what this reaction is called. Okay?
I know that sometimes, like, when I draw blood, and I don't know, the funny thing is, I know how to draw blood, and I do it all the time.
Yep.
I don't know all the science.
Well, now you're going to know the science. It's exciting.
So, like, sometimes there's a coagulant in tubes.
Anticoagulant.
Yes, anticoagulant in tubes. And sometimes there's not.
Correct.
So
why?
Like, well, I know. So
Well, let me tell you.
So they tell me to, like, draw for certain tests. you
Correct.
know, Like I was telling you about the trauma panel,
Mhm.
the metabolic panel and stuff. I actually
Did you
asked
figure
the
out?
doctor
Oh, good.
yesterday.
Did you figure out what the tests were in there?
A couple of them who's kind of a jerk to me.
Oh,
It was during trauma.
Oh, it was during a trauma. Well, he might have been a little busy. Probably not a good time to ask him that question.
I asked him, like, after the patient was already there, and he was like, you should know this. And I'm like, I don't know. So, and that's how they are. But I just...
All right, let me give you a quick answer to your question. So in the lab, you have testing that you can do on blood, tons of different things.
Yeah.
Now, when I take blood out of the body, guess what's going to happen when I expose it to the air? That. It's going to automatically kick into this chemical reaction and create a clot. Two different tests I can do, though. Sometimes I don't want that to happen to my blood because it pulls out some important substances that I actually need to test for. So when I draw blood with an anticoagulant, I'm stopping this from happening so that I can test all of the substances in plasma. And different anticoagulants will serve different purposes, but eventually all of them are going to stop the clot from forming. In the chemistry lab, I actually want to get rid of some of these things because they're just kind of useless to me and I don't really care whether they're there or not. So that's when I take blood in a plain tube, one without anticoagulant. I don't care if this happens. If it happens, that's fine. I don't care about the red blood cells. I only care about what? The plasma. So I spin it down in a centrifuge, get all that crap out of my way, and actually the clot kind of helps me because it keeps it to the bottom, and I can test. So you can either do blood tests on plasma, which is including all of the chemicals in the clotting cascade, or you can do tests on serum, which is minus all of this stuff.
Yeah, because a lot of times they're like, oh, they clotted, so you have to redraw.
Exactly.
So, and then, like, they can't do the test, so I have to redraw.
Yeah. And different anticoagulants will disrupt different testing methods. It'll mess with the chemistry.
Okay.
Does that?
No, it does make sense.
Yeah.
I should probably have known that. I mean, I took a phlebotomy course, and actually it's in the medical center, and I did all the tests.
See, if I had been teaching your phlebotomy course, you would have known so much more.
They didn't explain all
That's what I
that
used to
stuff.
do for a living anyway, so
It was awful.
that's the only reason I know.
Now I know.
So what's that? It's a clot. And it catches whatever's around it. So when we look at the clot or we look at a scab, and we talked about this when you talked skin, are you supposed to pick your scabs? No. What's happening underneath? Yeah, the cells are coming together to form sheets to grow up. When's your scab going to go away? When they've filled in and grown up. Stop it. Don't pick your scabs. And when we're done with this, what do we do with it? Do we just let it go? Yeah, well, we just let it go. We can't just let it go. If we let it go in the circulatory system, what's it going to do? Yeah, block something up, which probably wouldn't be a very good idea. So the next part of your textbook talks about reversing the chemistry. Once I've formed that clot inside and done my road work, done my repair, now I have to do what? Yeah, turn that fibrin into liquid again. So that's what they talk about under clot retraction and fibrinolysis. I basically have to turn it back into a soluble protein. So, basic understanding of the definition of clot retraction and fibrinolysis. So there's, again, platelets are going to help me with this. There's chemicals inside those platelets called platelet-derived growth factors that are going to help with the process of fibroblasts, helping with fibrinolysis. What's a fibroblast?
It's the mesh, yes?
Well, it's a cell that's in connective tissue, okay, and that's going to help with the process as well. It's the guy that made collagen fibers and reticular fibers. Remember that guy?
Yeah.
Okay. So, we want to be careful with clots. We want to limit their spontaneous formation. We don't want them floating around. What's the difference between a thrombus and an embolus? Embolus is a clot, thrombus, on the move. We don't want any clots on the move in the circulatory system, do we? No, because they can cause problems like what? Pulmonary embolism, myocardial infarction, stroke. Yes?
Yeah.
If I plug up a pathway of circulation, everybody on the other side's not getting dinner tonight. And what's going to happen to those cells? They're going to start to die.
Can you clarify what you want us to know on the test for this? Like, do you want us to know everything of hemostasis, including coagulation? Or
Yes. So I want you to know the the steps of hemostasis. I want you to understand intrinsic, extrinsic pathways leading to this coagulation that we see on that diagram. And again, just basically the stuff that's in white, okay? Know that there's two ways to get to a common. The common is the Prothrombin Activator, and then the little pathway under that.
Can you please explain, so when we have blood vessel and we're forming this clot, we have injury, blood vessel, so how blood still moving throughout the body? If there's a
Think of the road. Okay, now I'm in a tunnel. Be in a tunnel, not just a road, in a tunnel. Okay, I'm in the tunnel in Boston. You ever go to Boston? You're underground. You're under the ocean. And you're driving along, which always freaks me out just a little bit. And one of the tiles falls out. Poop! and the water starts to come in. But everybody's still driving. Can they still drive in the road?
For a little
Yes.
while.
But then what do I have to do while everybody's driving in the road?
Fix it.
The fixer guy has to come and grab one of the tiles and do what? Fix it. Circulatory system, blood running through the tunnels.
Okay, so
I'm going to
this
have to
mesh
repair. It's going to hang up on the ceiling.
on the ceiling, okay.
Yes?
Okay.
Makes sense? And then when I'm done, I can't just rip it off and let it go. I have to do what?
You have to rid of this.
I have to turn that solid back into a liquid so it can run. Fibrinolysis. Make sense?
Yeah.
A clot's different. But if I took that and I ripped it off and I let it go, what's going to happen to the tunnel? We've got a big tunnel. It's eventually going to be,
Narrow.
it's going to be that little now where all the cars have to go through one by one. And that big clod is going to plug up the works. Make sense?
And that will actually decrease, not increase actually, or decrease your blood pressure.
Well, in that area, absolutely. Okay? Did that help?
Yeah, thank you.
So know the difference between a thrombus and an embolus. They also define different, and then of course, anticoagulant. Does everybody understand what that is? So it's a chemical that's going to do what?
It's gonna thin your blood. It's gonna cut off the clotting stuff.
Right, it's going to disrupt something somewhere here so that this doesn't happen. Okay? And different ones will do it in different ways. Heparin, Coumadin, you've probably heard these, you work in the hospital.
We had a patient just pick a small, tiny scab. She just scab, and she bled out 2 pints of blood. Wow. Yeah. And it was like in an area that you couldn't really see. Like
Well, you're pointing to your head. Why do you think? Anybody have children? Yeah, they get a cut in the head. It's like, holy crap, I never saw so much blood in my whole life. Why?
right here.
Well, yeah, you kind of got a brain up there, so you have quite the blood supply up in there. Yeah.
We went in.
So they bleed, yeah, they can bleed really bad.
Second, and then I came out, and I was out for like an hour, and I walked back in, and there's blood everywhere on the pillow. And she
Yep.
was just laying there.
Well, and it was probably in a place where there might have been a small, small artery close to the surface. Hello.
Yeah, it was crazy.
Yeah, that can be a little bit scary.
Problem.
Yeah. Okay. Bleeding disorders then. Anything that's going to disrupt clotting cascade, anything that's going to disrupt platelet formation. I don't have enough platelets. I have too many platelets. What's thrombocytopenia? And not enough platelets. Why is that a problem? Going to have problems.
You're not going to be able to plot it.
Correct. Impaired liver function. What the heck does the liver have to do with anything? Oh, yeah, red blood cells. We're talking platelets. Oh, we forgot to mention, what was it that caused that hematopoietic stem cell to become a platelet? EPO's red blood cells. Interleukins and cytokines were white blood cells.
Vitamin K,
Nope.
vitamin K can cause
What makes a hematopoietic stem cell become a platelet? What was another name for a platelet again?
thrombocyte.
Thrombocyte. Thrombopoietin. Ah. Who makes thrombopoietin? Guess. Liver. So when I have patients with cirrhosis, for example, or any disease with impaired liver function, what is the secondary effect in my patient? Bleeding disorders, yes.
It's not funny. I know this guy that had an issue with his liver because of drinking.
Yep.
And he just had a stroke, and they said it was completely unrelated, but how could it
Yeah, it probably was somehow related. Yeah. Indirectly, but yeah,
explains it right there?
correct. So impaired liver function is going to be a problem with clot formation because of several different things besides the fact that thrombopoietin is one of the chemicals that the liver makes. Hemophilia is a problem with one of the factors in the 13, factor 8. It's called the anti-hemophiliac factor, deficiency in this. Also other ones like factor 9, factor 11. Again, I'm not going to make you memorize all the different factors, but understand that hemophilia is a bleeding disorder related to a deficiency in what? In the clotting factors. Okay? And then they also talk about disseminated intravascular coagulation. And this is when, again, some reason, and there can be so many reasons, but a patient is, yeah, certain clotting factors.
What was the last one you said?
DIC, disseminated intravascular coagulation. And again, for whatever reason, and there's a bazillion reasons, some sort of chemical disruption, some deficiency, something going on in the patient is causing them to do what? DIC.
It causes clots, like
Spontaneous clots, yeah. And again, that's going to be a problem, right? Because we're... Correct. Okay, now, here we're going to enter, and sometimes this is confusing, and hopefully it won't be confusing. I'll try to make it unconfusing. They talk about red blood cells and antigens and antibodies. And they talk about transfusion and blood replacement. Now, has anybody ever donated blood? Why is it important for you to donate blood?
There are different types of blood.
Oh. Yeah, and we're going to talk about that in a minute. But why do we still, I mean, guys, we're so smart. Isn't there a chemical we could, give them in place? No. We still haven't developed tons of reasons. Those cells, the cells that we're talking about, we haven't been able to replicate their actions in the lab. We just haven't done it very well. We're working on it all the time, but we still haven't got the replacement for actual blood. So when patients lose too many red blood cells or go through diseases where they're destroying cells at too rapid a rate, they are going to need a blood transfusion. Now, I can't just go and say, here's my blood, give it to any Joe Schmo, because we also have to take into consideration our immune system. Our immune system has the job of doing what for us? Defending us against what? Foreign substances. Now, your substances are not foreign to you, but they might very possibly be foreign to someone else. So when I talk about foreign, that word foreign, what your immune system is constantly looking for are these foreign substances. Let's give them a name. Do you know what they're called? Antigens. Now, these are protein-like substances. We can find them on the surface of any living cell. You have certain antigens on your cells. You have antigens on your cells. All our antigens, are they the same? A lot of them are similar, but some of them are different. And that's what my immune system is constantly looking for, to make sure that what's in my body belongs to me. When we talk about blood, there's very specific antigens that can cause all sorts of big problems if I get the wrong ones into my system. And we're talking about a group of antigens called the ABO blood group antigens. These are antigens we're going to find on the surface of our red blood cells. Now remember, blood volume. What's most of blood volume besides plasma? What's the other biggest part? Red blood cells, right? Erythrocytes. If I give you foreign erythrocytes with respect to these ABO blood group antigens, we're going to have some big trouble going on. Because your body's going to recognize them as what? Foreign, and what are we going to do? Attack. Yes? We're going to talk about this type of reaction when we talk chapter 21. But in this chapter, we're going to talk about these antigens. So, there's different blood types. I can be type A. I can be type B. I can be type AB, or I can be type O. I'm going to give you a little genetics lesson real quick. For every single protein you make, you have two sets of information, two genes that are going to code for that protein. Yes? With respect to blood type, and I'm going to make this simple, we're going to call those two bits of information you have I. Why do I have two? I got one from my mother, I got one from my father. We'll call them I. Now, I can either have, and there's three different alleles, three different bits of information I can possibly have. Even though I can only have two, for blood type, there's three. I can have this, IA. If I have that, what am I going to make? A what? Antigens. And where are they going to be? On the surface of my red cells. I can also have IB. If I have that, what am I going to do? Make antigens. What type? B antigens. And where are they going to be? On the surface of my cell. I can have both.
Okay. First of all, you said that ABO on the surface of the red blood cell.
No. Listen, we have to listen to this explanation, then we'll understand ABO. So you can have an A to make A antigens, or you can have a B to make B antigens. I said there was three, didn't I? If you have this one, we'll call it little I, you're not going to make either of those A or B antigens. No. Kind of common, actually. Now remember, I said what? You have two. Yes? So here's you. So what are all the possible blood types? Well, I could get an A from my mother, and I could get that from my father. What does that mean? I'm going to have the gene to make A. I'm going to have type A blood. What's another possible gene combination for me to be type A? Or I could be this. Two copies of information. Yes? One from mother, one from father. That's type A. What else could I be? Same as with A, yes? I could be this, or I could be this. But what does that mean? That means I have the gene to make the antigen. It's on the surface of my red blood cells. So we've already talked about this guy, and we've talked about this guy. Yes? I could also, exactly, so I could be this. What type blood do I have? AB. What's that mean? I got both. I have A's and B's on the surface of my red cells.
Okay, how about if my mother is AB, my father is A?
Okay, let's finish the last one, and then I'll show you that. Or I could be this. And then I'm type what? And what's that mean? I don't have A or B. Don't say I don't have any, because those aren't, no, I don't have A and I don't have B. I know that sounds confusing, but I'm going to tell you something now that's going to confuse you even more. You'll have neither antigen. You still have other antigens, but they're not A and they're not B. Okay? So you're O. Now here's the scary part. We don't understand it. Normally, you will make chemicals to neutralize foreign substances when foreign substances come into your body. Do you know what that chemical is called? Antibodies. Okay? So you will make antibodies which will neutralize foreign antigens when they come into your body. Like chickenpox, for example. That's a nasty little virus. Anybody have chickenpox here? When it comes into your body recognizes it as foreign. You'll set up an immune response. We'll talk about that later. And you'll make antibodies against it. And typically, except for this case, that's the only time you'll make antibodies to an antigen. This is an exception to the rule. For some reason, and we still don't know why, you will make antibodies against the antigen you don't have in the ABO blood group. So back to my patients. I have a type B person. They have B on the surface of their cells. What don't they have? A. They will make anti-A antibodies, and they'll be floating around in their circulatory system. Again, we don't know why. And it's just for A and B, yes? If I'm type A, that means I have A antigens on the surface of my cells. What antibody? I will make B antibodies. Why? No idea, but we spontaneously do it. What if I'm type O? Yeah, I don't have A, I don't have B. I'm going to make both antibodies. What if I'm type AB? I don't have anti-A and anti-B antibodies. I don't make them because I have the antigens. Again, this only happens here. We don't know why. And it's only for the A and B. Now, sometimes your body will do weird things and make antibodies against other things, but normally it's just these guys. So when we give blood to a patient, and I think I said this last class, we are giving them just the red blood cells, because that's what we can't replicate. So we pull out the red blood cells, we wash them off, we put them in some saline, and we put them in a bag for our patients. Well, who can give who what? This guy down here sometimes gets referred to as the universal donor. How come? I can give O cells to type A, can I? Yeah, because there's nothing there that's going to react. And I can give O cells to all these other guys. Can I give type A cells to type O? How come?
Because type O has both A.
Exactly. Big trouble for type O. So what's the only type of blood I can give a type O person? Type O blood. Sorry, I forgot to mention, there's another antigen we have to think about. Yeah, it's called RH.
Well, that's why I said
Now this, yeah, RH negative is rare. Type O is not rare. It's very common.
Type O can only have type O. That's why I was saying.
Yeah, but the blood type O is very common.
Okay, well maybe that I got that.
O negative
Blood
is not.
Like, I used to donate blood every 6 months, and then when I stopped for a couple of years, the Red Cross started calling me because I have O positive blood.
No, they'll call you.
They'll call you for anything, but when I asked her, I'm like, why do you guys keep calling me for this? She's like, well, you have O. Yeah. She's like, you have O positive blood. We can give blood to everybody from your blood. And I was like,
Well,
okay.
I donated one time. And they
not
called me
everybody.
every single day
They call
for
me.
3 months.
Actually, O negative is better. Okay, now let me explain the negative and the positive part.
O
Yeah.
How about
Let me,
A
wait.
negative?
No. I'm A positive, by the way. A plus. All right, so wait a minute. This other guy, he kind of throws a monkey wrench in there. He's also another antigen on the surface of red cells. Now, if you have Rh antigen along with your other antigens, you are Rh positive.
Hold on, say that again.
So, I'll give you an example. I'm type A. I'm A positive. So what do my surface of my red blood cells look like? All right, I have A, what are they making, triangles? I have A antigens on the surface of my cells, but what else do I have?
You have B antibodies,
Well, I have B antibodies,
RH.
and then I also have, I'm going to make them squiggles, I also have Rh antigens on the surface of my cells.
So it's also in the surface of the cell.
Correct. If I'm Rh negative, what's that mean?
You don't have the
I don't have the squiggles.
Or does that mean you have the opposite of the squiggle?
No, I mean,
Nope,
You don't have
I just don't have them.
You don't have them, so you can give your blood, and anybody, even with plus, can receive it.
Correct. Now, I'm glad you said that, because the Rh guy doesn't follow the A and B rules. So if I'm Rh negative, whatever my blood type might be, I don't have any antibodies to the Rh antigen in my circulatory system. Okay? The only time I'm going to get them is when?
Pregnancy.
If I get what into my body.
if you get the antigen.
Yeah, for some reason I get the antigen into my body. So if I'm an Rh negative mother and I'm pregnant and my partner is what? Rh positive.
Doesn't matter. Can be even negative, and you will still have baby who is positive. Doesn't matter.
Well, it does matter for the baby. The first pregnancy is okay. No matter how easy your delivery is, no matter how easy your delivery is, what's going to happen during delivery? Your blood is going to mix with your offspring's blood. If you're an Rh negative mother and that Rh positive blood gets into your circulatory system, what are you going to do? You are going to create an immune response. It's going to be fine. You're not even going to notice. Immune response, you'll make cells. You'll start to make anti-Rh antibodies. And they'll now be circulating around in your circulatory system. Let me finish, and then you can ask your question. What happens when baby 2 comes along?
If they're RH negative or positive, you're gonna.
If they're Rh positive, and I have Rh negative, if I have Rh, anti-Rh antibodies in my circulatory system, they're small enough, those antibodies can transfer across the placenta to my developing offspring. And they're going to attack my developing offspring cells.
Isn't there a shot you can get?
Yep, that was my next step. So how am I going to prevent that from happening? I have to kind of trick my immune system. Correct. I have to give you anti-Rh antibodies just around the time before you deliver, around right after you deliver, in and around that time frame. I'm going to give you the antibodies to the antigens that might enter your system during delivery. That's going to trick your immune system into not going through that whole spiel of an immune response. The antibodies I give you are going to neutralize the antigens that enter your serum or enter your body. Your body's going to clear it.
Who's at risk? I'm not trying to...
Who's at risk? The next baby that comes along.
What happens to them if you don't?
Your antibodies will attack their cells and kill
Die
them,
every time?
pretty much.
Can I
Second pregnancy maybe can be saved with a transfusion right at birth, but third, forget it. Not going to happen.
Can I ask you? So you're saying, if I understood right, that it doesn't matter. I mean, it's matter that if your partner, your husband, let's say, you have negative blood, your husband has a positive, and that's how baby can be positive as well.
Correct.
But in situation when you're negative and your husband is negative,
You don't have to worry about it.
no, unfortunately, no. Because
Really?
From my own experience, because my
Yeah, but-
baby was positive.
But but were you pregnant before that?
And
Did
I
you?
was baby.
Okay. So somehow,
But the thing is,
how was the baby positive?
I ask you because you're professor here.
I don't know about that one.
Yeah,
But
that's why
But look at the genetics again. So if we say Rh positive, we have two genes. The name of this gene is D. Okay, so you can have big D or little d. Little d would be the absence of. You're going to get two copies. Yes? So if you have an Rh positive male, he could give you, or the offspring, one of, because an Rh positive male could be this, right? And an Rh negative female would be this. Correct? So anytime you have the chance that your offspring will have the Rh gene, you have to make sure that RhoGAM is administered. Otherwise, mother will produce antibodies against the Rh antigen, and her antibodies will attack the child during pregnancy.
can two positive blood can produce, husband is positive and mother is positive, can child be negative? Because I'm negative. My
Watch.
mother is
Watch.
positive.
You're only going to give one to your offspring, right? What if I give this? Right, so the baby is negative, even though the parents were both what?
Yeah,
Positive. Same thing with, I'll ask a question. Sometimes I do this with my Gen Bio students. Mother with type A blood mates with a father with type O blood, and the baby is type O, and the father said, or the baby's type A, and the father says, that couldn't be my child. Well, can it? Yeah, because remember, you can be this, or if you're type A. So if you mate with a recessive, that's the way you kind of find out what you are. So if you have some kids that are type A and some that aren't, then you know you're what? You're this. You're heterozygous for this trait. If all your children, it's hard in humans because we don't have that many offspring. If we were a fruit fly and all of our offspring had type A blood, then we would know we were what? We were homozygous dominant for the trait. Okay?
So still there is a chance, because it happened in my life, that it was positive.
Well, there's so many different reasons why that could be, and we will not talk about those today.
What do you mean?
Well, there could be some reason that you were exposed somehow to anti-D antigens, and it could have been through other things besides pregnancy. So if you were exposed to the D antigen, maybe when you were, you somehow produced antibodies. Now, it didn't necessarily have to be through pregnancy. You could have been exposed to them, in an injection in the hospital. Oh, sure. So do me a favor. Time is over. But do me a favor and read over, understand blood typing, understand who gets what, understand what they look like. And you'll talk about that in lab, but what you do is you actually test the cells with prepared antibodies. So when you test the cells, you're looking for the presence of the antigen by adding prepared antibodies. So if I'm type A and I add anti-A antibodies to my cells, what's going to happen? They're going to clot. Okay?
This is the clot?
Yep.
Oh, okay.
So imagine these floating around in your circulatory system. That wouldn't work so good. Okay? So, ready for a test? On.